You can see my presentation. Is that working?
It is, thank you.
Yay! So this isn't a long presentation, and it's not something super heavy or that you have to remember or learn. It's actually more just out of interest, really. It's something that I did for Gynae Journal Club, and most people just found it quite interesting. So I thought I'd share it because I had no clue about most of these things before I looked at this TOG article. So we're going to be looking at options for acquiring motherhood in absolute uterine factor infertility, which are adoption, surrogacy, and uterine transplants. And that's basically what we're going to go through. So AUFI is a form of infertility whereby conception and or the maintenance of a pregnancy is impossible owing to uterine absence or dysfunction. So in terms of congenital causes, we've got Meyer, Rokitansky, Custer-Hauser, which I'm sure has gained a letter since I learned it at medical school. But it's a genetic condition that affects 1 in 5,000 and leads to the lack of development of the uterus and vagina, but normal external genitalia because they do have ovaries. They don't menstruate due to a lack of uterus, and primary amenorrhea is usually the first symptom. Or acquired, which can include following hysterectomy or from uterine pathology such as severe Asherman's. Asherman's is an acquired uterine condition that results from the formation of adhesions inside the uterus and or cervix, and you can see that in the images on the right-hand side. In terms of following hysterectomy, I told you I'd tell you about a sad case that I had at the John Radcliffe. So I was doing my labour ward SHO shift, went to triage, and there was a 16-weeker who was complaining of PV bleeding and a feeling of something dragging down below. So I went to speculum her, and she basically just had a massive cervix, which was really irregular and friable. So I went to go and I was like, this something's not right here. So I went to go and get my registrar, and she had a look, and she's just like, that is terrible. And I think she'd had a smear maybe 4 years ago, but it's that classic thing of, oh, I was due it before I was pregnant, and then I got pregnant, and blah blah blah. I can't remember what happened, but obviously she was referred to colposcopy, and after subsequent investigation was found to have reasonably advanced cervical cancer. And at 20 weeks, she had a hysterectomy with the fetus in situ. This was her first pregnancy. So she had a hysterectomy with the fetus in situ and opted against feticide. I think their womb was opened after the operation so that she could see her baby if she wanted to. But anyway, very sad. And patients in this situation are obviously absolutely devastated by the loss of their baby and can't, imagine not being able to conceive again. It can follow years of unsuccessful hysteroscopic procedures as well, and obviously a long-term emotional burden, lots of MDT required. There are around 50,000 women of childbearing age in the UK that don't have a viable womb, just something to think about. And until recently, the only options to acquire parenthood were through adoption and surrogacy, but there have now been more than 70 uterine transplants with at least 18 live births. So, that's an alternative coming in the future with some significant risks. And we also need to think of transgender women now. I think there will be a big move for uterine transplant in these patients, but we will find that a lot of studies will not include them to start with. So adoption, if you want to do some homework, which is fun, and you've got Apple TV, you should watch Trying, which is a really good program about 2 people living in London who failed to conceive and all of the hoops that you have to go through to try and adopt. So adoption is the permanent transfer of parental rights and responsibilities from a child's birth parents to their adoptive parents, which provides social and legal parenthood and an opportunity to enhance the lives of these children. So in 2018 to 2019, there were over 78,000 children in care, and only 3,570 children were adopted in the same period. Obviously, it's associated with challenges and attachment-related difficulties. So 63% of these children will have experienced neglect, and they're likely to have emotional, behavioural and relationship difficulties. So it's not something to go into lightly, and it's not the same as having your child afresh, essentially, and being able to nature versus nurture it into, your own child with no history of neglect or, relationship difficulties. It's not an easy process, and it starts with evaluation, which involves background checks, references, home visits. Do you have enough space in your house? Do you have enough money? You then go on to a training period, detailed assessment period. You search for the appropriate child, and the matching process can take 2 years. And there's no guarantee that after 2 years you will end up with a child. So it's not something, and you can imagine this whole time you're, getting a nursery ready or thinking about how you're going to, raise a child, and you may actually never get a child. So it can be devastating. There are cross-border adoption. That's the legal adoption of children born in other countries and accounts for 30,000 adoptions worldwide. Obviously, there are issues surrounding potential exploitation and safeguarding and the cultural identity of adopted children. But you'll find that a lot of other countries have more younger children, which is obviously what people want, generally what people want. And some of the rules in other countries regarding adoption are more lax, so it's easier to adopt in other countries. So surrogacy is a process whereby a woman gestates and gives birth with a prearranged plan of giving the child to another person, the intended parents. There were 167 children born by surrogacy in the UK in 2017, and you can either be altruistic or commercial, which is paid. Paid is allowed in some states in the US, Russia, Ukraine, and Georgia, but there are risks of exploitation of vulnerable women, because if you can pay someone to do something, then in theory you can get them to do most things, including carry a baby. Only altruistic, so where you do it out of the kindness of your heart, is allowed in the UK, Australia, and Canada. And in a third of the population in Western Europe, China, and Japan, you are not allowed to use surrogacy. So in terms of different types of surrogates, you'll find that most are host or gestational. So the eggs come from either the intended parents or from a donor egg. So no genetic makeup is from the surrogate mother. Full is where a surrogate provides their own eggs and is just genetically related. In the UK, surrogacy is permitted, but agreements are not legally enforceable. So the surrogate is the child's legal mother at birth. And if the surrogate has a partner and is married, then that is the child's father until the legal bit has been done, regardless of the origin of the gametes. And UK surrogates can be compensated with reasonable expenses only, with the average cost of surrogacy being around 25,000. The surrogate transfers legal parenthood to the intended parents 6 weeks after birth, and the surrogate can decline to relinquish the child, which makes surrogacy less desirable for some. There's also a risk that the surrogate that the intended parents can change their mind. So, example, if the child was born with a severe disability, the parents may decide that they actually don't want that child. And you can use cross-border surrogacy because there can be fewer restrictions abroad and a greater pool of potential surrogates, like in America. And most surrogates have reported positive experiences with no long-lasting psychopathology, but one study did find that more than a third of surrogate mothers found it difficult to relinquish maternal responsibility, which is not overly surprising. This is an article which I came across. A Russian woman, 24, who has welcomed 21 surrogate babies in just over a year with millionaire husband, 57, insists she's a hands-on mum despite spending £100,000 on 16 nannies. This is in Georgia, the country Georgia. They have used surrogate mothers, which costs $9,707 per pregnancy. And the state of Georgia has allowed surrogacy since 1997, as long as the couple involved are heterosexual and married. And in Georgia, the child that is born automatically goes to the people who provided the genetic material, and the surrogate has no rights. And they say that Christina's potential surrogates go through counselling and sign legal paperwork. And women who've already had one pregnancy are chosen. And Christina reveals that one of the surrogate mothers wanted to keep the child after it was born. But anyway, yeah, so you can see the potential. I mean, this woman says that she wants to have 105 biological children, which seems just an awful thing to do. But yes. Okay, uterine transplant. The more actual relevant bit of the talk. So this entails the transplantation of the uterus, including the cervix and the surrounding ligamentous tissue, and the supply and draining blood vessels. The only intervention that restores reproductive anatomy and functionality and enables the actual experience of gestation and gestating a baby. It is intended to be temporary, which is really important. So the transplanted uterus will be removed after 1 to 2 successful pregnancies, and we'll find out why later on. So the process, the patient wanting a uterine transplant undergoes egg retrieval, and these are frozen until they're required, and then the patient waits for an appropriate uterus. In terms of who can provide a uterus, it can be live or deceased. Live came first, with the deceased following a few years later. We haven't been able to do much research into the success rates of live versus deceased, but we know that generally live solid organ transplants do better. The uterus retrieval surgery in the donor is a 3-hour operation. It's the uterus, 2 arteries and 4 veins, and the uterus can be stored and it can tolerate being cooled for up to 24 hours. The recipient has a minimum of 3 surgeries to look forward to. The first one is the transplantation surgery, which is a 6-hour operation at least. The recipient is placed onto immunosuppressants post-op and can be in combination of 4 different drugs to stop organ rejection. The frozen embryos are thawed a year later, and when we're sure there's no rejection, implanted into the donated uterus. You then have a cesarean section, which is the only way to deliver donor uterus babies, and then at some point later you will have the 3rd operation to remove your womb. Let me see if I can find. Can you see this video?
Yes.
There won't probably be any sound, but you can glean what's happening from the animation. So that's basically it. I'm not going to go into a lot of where things are implanted or not, but there's like so many reasons why you shouldn't have why you shouldn't have a vaginal delivery. Always.
Did they not have a cesarean hysterectomy at the same time? Like they have to have a 3rd operation?
So good question. I think no, because the hysterectomy would be a lot more risky because you've got a gravid uterus, and also some women want to keep it in order to see whether they can have children in the future. But yeah, a gravid uterus is going to be like way more vascular and it's going to be a really tricky operation. So no, they don't plan to do it at the same time.
Do they connect up Oh, sorry. Well, I'm sorry. It's just like on that video, did they connect up the uterus and cervix to the vagina, or?
Yes, yeah. So it kind of like goes where it's supposed to go, but can't really be used in that way because there'd be so much scarring. But yeah, they connect like it was your own uterus.
I guess my question would be, where would they get the uteruses from? Is it kind of like in the same way you donate organs when you...
Yeah, exactly that. So you could have any part of a person who died in theory. It's just that up until now, we had no way of using a uterus because we hadn't started doing uterine transplant. As we'll see, there have been a few live donors, which have been parents who've donated, like mothers who've donated their womb to their daughter.
Okay.
And is there a, sorry, Sophie, is there an age limit or like menopausal status limit?
So that entirely depends on where you are in the world. As we will see in the UK, we are only just in trial phases and there are lots of stipulations. I think the woman who donated her uterus to her child was like in her 50s. But I think I'll see in the later slide, but I think that was a successful transplant. Okay, so what has the journey been to get here? So in terms of before this time, in 1896, an Australian working in Vienna published an ovarian autotransplantation for a rabbit. Then in 1964, at the University of Mississippi, a dog uterine transplant was done and a pregnancy was established and live offspring delivered. In terms of actual humans, in 1931, the Danish artist Lily Elbe, who was a trans woman, underwent a I think this was this what that the Danish girl was that?
Yeah, there was a film.
Yeah.
I literally only just clocked that. Anyway, she underwent a uterine transplant hoping to have children. When she was 48, she got a post-surgical infection and died from cardiac arrest 3 months later. More modern day transplants in Saudi Arabia in 2000, a uterus was taken from a 46-year-old patient into a 26-year-old patient who suffered infertility following a PPH. The uterus was removed at 99 days due to necrosis, but they say it was successful because the uterus did function for 2 menstrual cycles. So look, you can menstruate. Turkey in 2011, uterine transplant of a deceased donor into a 21-year-old with an absent uterus, and she was the first pregnancy. The first pregnancy resulted in early miscarriage, but the second pregnancy carried on to 28 weeks, and the baby was born in 2020. And then in Sweden, it was the first mother-daughter live womb transplant in 2014. The donor was 61, and the recipient was 36 with MRKH. She had a combination of tacrolimus, azathioprine, and steroids for suppression. She had 3 mild rejection episodes reported but resolved. The first baby was born in 2014 at 32 weeks by C-section. And Sweden are at the top of their field, so they've done 9 uterine transplants and 7 have been successful in terms of having live offspring. And then also India, United States, and all around the world. So progress. Not all data is readily available, but in a recent review of 45 cases, there were 18 live births, but more than a quarter of cases require an emergency hysterectomy at some point, whether that's before having a baby or after. Additional 10% suffered complications, necessitating further surgical intervention. In terms of rejection, apparently the only way to detect is via histological assessment via multiple cervical biopsies, and obviously only after 6 to 12 months after stabilisation on non-thoracic immunosuppression regime can the embryo be transferred. High risk pregnancy care needs to be in place after this with maternal fetal input. The aim is to deliver the fetus at 37 weeks by section. I'm not sure how many have actually got to 37 weeks, but we have to be careful because there is a potential for painless labour, and then that brings a risk to the structural integrity of the graft and the vascular anastomosis during contractions. After hysterectomy, immunosuppressants are stopped to reduce risks of long-term morbidity such as infections and neoplasia, and then obviously the uterus is removed. So why haven't we been doing this before, and what do people feel about it? So we had quite a good debate with one of my consultants, but it costs £100,000 on the NHS to do a uterine transplant. And there are other ways of acquiring motherhood in terms of adoption and surrogacy, which, as we've discussed, do have their downsides and are not the same as carrying your own child. But when you do a uterine transplant, you are also causing a massive risk, which is also may well be an even bigger cost to the NHS with all of the emergency procedures that might be required. And it also can if you offer someone a uterine transplant, loads of people are going to want a uterine transplant. And they're not going to want to look into surrogacy and adoption of the children on this earth that already exist. But anyway, feel free afterwards to have your say. There's lots of obviously interesting discussion around it. I think this is the last slide in terms of what we're doing in the UK. So a study of women with AUFI reported that 97.5% of women would choose uterine transplant over surrogacy and adoption, being aware of all the risks. And a similar study in France showed that 58.3% would take part in a uterine transplant clinical trial. So in the UK, the trial is called In Situ, Investigational Study into Transplantation of the Uterus. And Hammersmith Hospital is the main base, but OUH are a collaborator. So I imagine some of the operations might be done at the Churchill, which would be really cool. They're still in the recruiting phase and they're only aiming for 10 patients across the UK. And it's a prospective trial using deceased donors, and the conditions that they will accept are MRKH, Asherman's, PPH, and cervical cancer, leading to hysterectomy. The inclusion criteria, you have to be aged 24 to 38. I think you can be 40 if your eggs were frozen at the age of 38. You have to have a normal BMI, less than 30, and normally functioning ovaries. It says the exclusion already had children, but I'm not sure how you can have had a PPH if you've not already had children. But anyway, poor health, significant comorbidities, major or multiple abdominal surgeries. You have to have a normal vaginal length, no renal pathology, ASA grade 1, and fluent English. The primary, if you've got a history of cancer, you have to have been in remission for 5 years or more, because there's obviously a high risk of recurrence with immunosuppressants. The primary outcome measure is the live birth rate at 5 years, and the secondary outcome measure is the pregnancy rate at 5 years and transplant success rate after 3 years. After the transplant, they have a year of monitoring on immunosuppressants, single embryo is transplanted, C-section at 35 to 37 weeks, and they are thinking about potential for a second pregnancy. The study completion date is 2024. So obviously this is a long way off, which is why I said at the beginning, this is not for you to learn and have to internalize, but I just think it's something interesting that in our lifetime and our career as obstetricians and gynecologists, that we will probably see this towards the end of our career. this is in the talk article about AUFI and parenthood. I just think it's quite useful to know, actually, instead of, if someone's infertile, wafting around surrogacy and adoption as options, because they are valid options, but it's not that they are really easy and straightforward and result in the same thing as having a baby yourself naturally. And that's it. Most of this comes from the TOG article, but then there's just a bit more on uterine transplant, which I got from other places. Any questions? Anyone have any debates?
Thank you, Sophie. That was so cool.
It's super
What do you
interesting.
think?
Like, sorry, Joe. I wonder how, like, when people are on the transplant list, they're prioritized according to clinical need or the date that they were put on the transplant. But how on earth would they prioritize this?
Exactly, because it's not like it's an actual I need it or I will die. It's an I want it, please. So I guess I'm imagining that a lot of them will be live donors. So we'll see quite a lot more of mothers donating uteruses because a lot of people will be considering a hysterectomy anyway. But then I would imagine that they'd have to be like thoroughly screened because, like 50% of the population have fibroids, but I don't think you'd really want a fibroid uterus inserted, given that that you're going to do a cesarean section. So I think they'd be like really stringent about, I don't know, I'm speculating because there is literally no current waiting list or guidance because it was so early. But yeah, it's would be really interesting. I'm guessing that people who had never had children before would be like top of the list. Maybe you can't even get on the list if you have a child, but who knows?
And then also, like, if you think it costs the NHS 100,000, like you think about all the people who, like, there's so many restrictions on IVF, like, where we are, you have the proportion of people who want IVF, there's only a small proportion who actually like classify for all those things. So it's just kind of like, well, people who have their own BYO uterus, like, we're not going to spend money on them, but we'll spend money on.
I know, but some people, and I do agree, some people feel that it is their human right to be able to carry a child inside them. So they would consider it a necessity to have a womb. Obviously, I can't tell you what it's like to not have a womb and be in that situation. But yeah, it's really interesting thing to think about, the ethical dilemmas.
I wonder whether it's going to be something that grows in the private sector mainly. So if you can pay, you can get it, or whether it will have to be something that comes centrally.
I don't know. I think there's going to be so much like regulation stuff that's going to be so hard to regulate. Maybe some of us will be on the board of creating these guidelines and stuff. But if you do hear about stuff coming through the JR and the Churchill, let me know in terms of uterine transplant, because I would imagine that if OUH are collaborators, then the Churchill will do some transplant surgery. Probably not under gynecologists, probably under the transplant surgeons and gynecologists, but it would be interesting, definitely, if we're around at the JR when that happens. It would be amazing to watch.
And so what do you think of this, Sophie, having done all this and like presented it and discussed it before? What do you think should be the, like, I don't know, societal outcome here? What do you reckon?
Do you know what? I really don't know, because like I said, you don't know what your opinion would be unless you were actually really in that situation and you were deciding whether you wanted the NHS to spend £100,000 and put your life at risk with immunosuppressants. But some people do just have, this inherent need to carry a baby, and their life will not be complete without doing that. So I don't know. I'm really on the fence about it. I lean towards, actually, it's really quite dangerous and quite expensive, and it's not actually necessary to save a life. So why would we do it? But I'm sure plenty of people would disagree with me.
And also, even if they get pregnant, like, you think about delivering babies, 28 weeks or whatever,
yeah, exactly.
And implications of that, like,
I think as we move on, the aim is 37 weeks. In the initial trials, it was obviously like 28 weeks and really early pregnancies. But I think as we move on, the aim will be, I don't think they would continue doing the trial if, everybody was being delivered before 30 weeks, because I agree. I don't think that's ethical, because you are creating a child that is potentially going to be quite disabled. But exactly, you're right. And you can't plan that though, can you? Because, you know, there might be an emergency, even with everything that you try and plan, there might be an emergency delivery that you have to do. So yeah. Good. Well, that was just something to wake you up at the end of the day, which I just thought was quite interesting. So thank you all for participating. And that's me done.